And we've got a few people coming in now. Good evening, everybody that's joining. You can see the numbers racking up, which I always say is very, very reassuring to make sure I click the right button. Good evening, everyone that's joining us. My name is Rosie Milsom. I'm the charity manager at Caudwell Lyme Co. And I'm joined here tonight by Dr. Ray Perrin, who I'll introduce properly in a moment, or allow him to introduce himself. I'll just make sure everyone has a chance to get on. And whilst we're waiting, I'll just tell you guys a little bit. So some of you will have attended some of the events that we've been doing over the past few months. So you'll know a little bit about them. But we started them based on kind of demand, really. We put out a survey to see what kind of content you guys wanted, because during the pandemic, we wanted to reach people out in their communities, and digital was kind of the way to do that, online. But we understand that really for many people in the Lyme community, the CFS community, you know, online is where their engagement is, because they're not always well enough to leave the house anyway. So we wanted to provide some interesting and engaging content that you guys could, you know, learn from, find out more about, stuff that would be interesting to you. So we sent out a survey. You told us the kind of stuff that you wanted to hear about, and here we are. So I'm really grateful to Dr. Ray Perrin for giving us his time tonight, and as I say, I'll let him introduce himself properly in a moment. So if you have questions throughout the session, do feel free to put them either in the chat function or in the Q&A function, and we'll go through. We've got some kind of pre-posed questions for Ray, and then we'll go through those questions at the end, so feel free to submit those. And I've just popped a little disclaimer in the notes. It's really just to say this event today, you know, is for information and interest purposes only. So it's not an endorsement of any particular practitioner or treatment. You know, any decisions that you make that might affect your health should be made under the advice of a medical or relevant and qualified health professional. But we hope you find it interesting and informative. And what time are we on? We've given everyone a couple of minutes, so hopefully most of the people that are wanting to be here today are on. So Ray, if you would like to give a little bit of an intro to yourself, a little bit about you and what interested you about working with ME and CFS fibromyalgia, that'd be great.
Right, okay, thank you very much, Rosie, and welcome to all of you. It's interesting because Rosie, we had a chat about a month ago, and I thought that was the meeting. I was already all dressed up in my fineries, and yeah, then
sorry about that, Ray.
And then I realised it actually wasn't. It wasn't, but it's nice that you're all here today, and on a sunny day in Manchester, which is unusual. So on with the show. So where do I come from? And some of you might have heard about my work before, but so I hope I won't be boring you with just a quick resume about how I started. I'm an osteopath by profession. I qualified in 1984 in the British School of Osteopathy, which is now the University College of Osteopathy in London. And I was making my name in sports medicine. That's what I wanted to do. I came up north to Manchester, where I grew up, and I set my practice up treating mostly sports injuries. And I was involved in treating quite, if any of you are cycling buffs, I know John Caldwell is a keen cyclist. If any of you do know about cycling, you might have heard of the Rally Banana team of years ago. It then later transformed later on to the Sky team that is quite famous, and the velodrome was set up in Manchester. So the cycling was really has had a large history in Manchester, and one of the cycling teams I was treating was the Rally Banana, and one of their members had ME for 7 years and wasn't racing anymore, wasn't really cycling anymore. He just go to work as an advertising executive, and that's all he could do. And he came to me, and he had back problems and postural problems, which I treat as an osteopath. And he said, "Has also got ME." Now this is going back to 1989. And in the 80s, it was known as yuppie flu. And I said, well, you know, young upward mobile person, you know, what professional, what can we actually do for you? But I thought that, I didn't say it, but I said, well, what we can help is a posture. And I worked on his posture as mechanics. And sure enough, his back problem that he had disappeared, which we hoped would happen as an osteopath. But his ME symptoms started getting better for the first time in 7 years. And he said after a few months, he was completely symptom-free. So he said, you know, you've cured me. And I said, I'm sure I haven't. But he said, no, I've been everywhere. You must have done something. So he was one of these patients that comes in with a whole wad of scientific data. And he said, here, read this and work out what you've done, because you've definitely found the answer to me at least. So that's how I started. And then from that, I started looking at other patients in the early 90s. And I wrote a paper in the British Osteopathic Journal, which was basically just a paper on clinical observation, saying that there's a mechanical problem in the spine affecting all these ME patients. And I then formulated a theory that if I'm working on the spine, I'm working on what's known as the sympathetic nervous system, which is the nervous system that controls automatic functions of the body. Mainly, there's also the parasympathetic nervous system from the top of the neck as well. And these areas I felt were problematic, but what was actually going on? And it was only later on I started investigating one of the areas, one of the physical areas that I saw was happening with patients is that they had enlarged lymph nodes in their neck and their armpits, but also they had lots of bobbly skin. I could only describe it as skin where I examined them, they felt these little like almost like bits of string underneath or worms underneath. And I thought, what's going on here? And it was only after doing a lot of researching at Manchester University Library that I found that what I was feeling was what's known as varicose lymphatics, that the lymphatics had actually reversed. And I started looking at the lymphatics more and more, and I realized that the sympathetic nervous system controls the lymphatics. And we were never taught that when I was studying physiology in the 80s. Nobody was taught that there was a neurological control of the lymphatics. It was only believed to be a pumping mechanism based on blood and muscles pumping the lymph out, a bit like a tube of toothpaste. And I realized then that there's a sympathetic control of the sympathetics, of the lymphatics. And then I started looking more and more into it. And I discovered so much science that was out there but hadn't been proven. But ME seemed to be, and the reason why I helped these patients was what I was doing to their bodies was stimulating the lymph, working on the sympathetics, and what the connection between the brain and the rest of the body was. There was an actual drainage system that was theorized that existed in the brain. And I thought lymphatic drainage of the brain, it was accepted throughout the whole of medicine that there was no lymphatic drainage of the central nervous system. But I felt that this is what I was doing when I was doing the treatment, which included cranial osteopathy, which is gentle pressure on the head and gentle pressure on parts of the spine, where we actually stimulate a rhythm to work better. Now this rhythm, I then learnt later on in my life, was the fundamentals of my work and was the actual drainage of the brain. So my theory was that by working on the lymphatics and working on the lymphatic drainage of the brain and the spinal cord, the central nervous system, and working on the sympathetic nervous system, we could repair the damage caused in ME and the disturbance and dysfunction of ME. It then took a lot more research to look into all this, and I spent a long time at Salford University developing my ideas and working on my originally a master's and then eventually a doctorate. And I have a doctorate, a PhD in the field of this neurolymphatic system involved in ME. And that's where I published my thesis, and I got my PhD in 2005. I then went further and wrote my first book in 2007 based on my thesis, but it was all theory. And since 2007, when the Perrin Technique first book came out, I've been working in the University of Central Lancashire in Preston, and I'm now attached to the University of Manchester, where I'm Honorary Clinical Research Fellow at the university's Faculty of Biology, Medicine and Health. And in the research I've done, we've validated a lot of my ideas, but luckily there's a lot of money in some research centres in the States where they've actually proven that the drainage system of the brain exists. And this has now been validated with scans, and we even have a scan in my new book where you can see quite clearly the lymphatic.
So what are we looking at in that image? What does that show us?
This green, this is the brain of a 47-year-old lady, and all the green in the picture, and these are the main vessels, but these are lymphatic vessels draining out from the brain toxins that are too large to go in the blood. The reason why we know those lymphatic vessels are actually lymphatic vessels and not just blood is because lymph drains the larger molecules. It was always believed that there was no drainage of large molecules in the brain because large molecules can't get into the brain in the first place. Because for anybody that knows a bit of neuroscience or biological science, there's a barrier, the blood-brain barrier, and that stops any large molecules entering the brain. And therefore, as many neurologists and doctors over the years have told me, that's why there's no lymphatic drainage of the brain. And you don't need one because large molecules can't get in. And this leads to a whole big, massive question mark, because if large molecules can't get in, therefore you don't need the lymphatic drainage of the brain, and therefore it can't go wrong, and therefore my hypothesis is completely nonsense. However, they didn't really think about the body and how it works, because if you look at every person in the world, as soon as they're born, before they're born even, they have a drainage system of the brain. They need to. Why? Because large molecules every second of the day enter the brain in the form of hormones. Hormones are massive molecules. Let's take insulin. Insulin is a huge molecule. It's the blood-brain barrier that stops any large molecules getting in. This is made of tight junctions, and only very, very small molecules can get into the brain, like water molecule. Water molecule is 18 Daltons large. Dalton's the name given to the size of a molecule, named after John Dalton from Manchester, dare I say, I made a plug for Manchester. And he was actually, I think, a professor at Manchester University. But so John Dalton, he just sort of developed the name, the Dalton was named after him, and the water molecule is 18 Daltons large. It's a very small molecule, H2O. Insulin is 5,808 Daltons. It's walloping, it's huge. There's no way it can go through the tight junctions of the blood-brain barrier. So how does the hypothalamus, which is in an organ in the brain, measure the insulin and other hormones like estrogen and progesterone? How does it measure those when these are huge molecules? And the hypothalamus controls the hormonal system by a mechanism that everybody in the world, in the medical world, accepts, called biofeedback. Hormones enter the brain, and then the hypothalamus measures the insulin and sends messages to the pancreas via autonomic nervous system and stimulates the pancreas to produce more or less insulin. And this is biofeedback. Right. This actually shows that large molecules do enter the brain.
Sorry, Ray, I didn't want to. I can see you're on a flow, but I don't want to go too far
too deep. Right.
But I appreciate it. So basically,
sorry, off what I am. So I'm not.
I know you're a scientist, and you want to kind of explain that, but I want to make sure we kind of stay on track and don't lose anyone too much in the medical knowledge. But essentially, what you're saying is, you know, there was a theory that things couldn't cross the blood-brain barrier in such a way that these kind of larger, like say, kind of lymphatic molecules, but the theories that you made around the causes of ME and CFS, and therefore the kind of management and treatment, have been kind of slowly proven, scientifically proven over the years, or validated in certain.
Well, now we know much more about the brain. We know that there are massive gaps in the blood-brain barrier, allowing these molecules in to allow the normal biofeedback of the hormonal system. And if large molecules like hormones get in, large toxins get in, and infections can get into the brain. And that's where the link to Lyme's, which we'll talk about later, comes in. But with ME, we're talking with post-viral, it's the post-viral illness. It's the, now with all the knowledge that is spewed out in all the data all the time about COVID-19, people know about the terms we've been using for years, like cytokines. You hear about cytokine storm in COVID-19, and this is and viral loads. So what's happening is, with something like, I mean, I know we'll talk about Borrelia later, but with Borrelia, you've got this bacterial infection, but you've got also the production of lots of cytokines, like with COVID. Cytokines are signaling molecules of the body's immune system. They basically, the signaling molecules basically are firing off, saying, "Cooey, here we are," and the antibodies come and attack the bacteria, the virus, whatever. So with COVID, the viral storm comes. Millions of viruses might enter the body at one time in one single droplet, which is why masks are so important. You know, we have, in my practice here, I'm in my practice now, we have the masks, we have the visors, and we wear them all the time when I'm treating patients, and the patients wear masks, because that reduces the viral load. And therefore, small molecules, small particles can only have a tiny bit of the virus in, maybe a few hundred viruses, and your body's immune system can cope. But if you have 1 million viruses on one droplet and it comes into the body, your viral load is so much. And then there's a massive cytokine storm. Loads of cytokines, interleukins, interferons. These are names that people might have heard of in chemotherapy. Okay. In chemotherapy, they use these. So what are they doing? What are the oncologists, what are those cancer specialists doing when they're treating the cancer? They send massive amount of these cytokines into the body that attach to the cancer cell. But since there's so many of them, they attach to healthy cells as well, causing all the side effects of chemo. But this happens when you have a cytokine storm, when you have a massive viral load, and also when you have a massive bacterial load in your body, maybe entering through into the brain through the passages, because the drainage of the brain has been proven. The drainage of the brain occurs around blood vessels supplying the nerves of the brain. The main nerve is the nerve of the olfactory nerves. That's the main drainage pathway. And you see this again and again with COVID. You're seeing the drainage, the virus going in through through this olfactory pathway, through a bone above the nose called the ethmoid bone. It has a plate with different holes in, perforations that allow the nerves to go up into the brain. And every nerve coming from the brain or going up to the brain has blood vessels. And those blood vessels have a space around it, around where the blood is, and that space is called the perivascular space. And that space has been theorized by myself and other scientists for many years to be the drainage of the brain, and it's now been proven. Scientists in Rochester University in New York showed the first scans of this drainage system in mice. Then it went further, and in 2017, that image of the human brain's drainage. So we now know that the drainage of the brain does exist, and now scientists and doctors are saying, well, what could this cause? This could be the root to lots of different disorders, and post-viral fatigue is one of them. That's ME. It doesn't always have to be a virus. It could be a bacterial infection. So you can get Borrelia and then end up with the post-bacterial infection. And it's again, the cytokines and the bacteria itself could actually drain into the brain the wrong way if the brain is not draining out correctly. And this happens when the sympathetic nerves don't work, because the sympathetic nerves control the lymphatics. So if they go wrong, then they cause a problem to the whole drainage system. And it's very interesting that women suffer from these disorders usually much more than men.
Yeah, it's something like 70% of people who suffer with chronic illness conditions like ME, chronic fatigue syndrome, fibromyalgia are women or something.
The same with the post-COVID, the long COVID that's happening now. And the reason for that is this hormonal link. The hormones are with women, the hormones change every month, and you've got this irritation of the control mechanism of the hormones, the hypothalamus. And the hypothalamus happens to be one of the main centers of the sympathetic nervous system. So when that gets poisoned, if poisons come in to the hypothalamus and it's trying to cope with all sorts of things going on, as well as the hormonal changes all the time, and that's more with women, then you end up with a buildup of poisons in this area. And it's been proven now that the poisons, when they go the wrong way, when they don't drain out, they build up around the thalamus and the basal ganglia, which are areas of the brain right next to the hypothalamus and connected to it. And these cause symptoms. These cause the main emotional symptoms that you see with chronic fatigue, with fibromyalgia and Lyme's and post-COVID, because this is the limbic system of your brain, the emotional side of your brain.
Well, that was going to be one of my kind of next questions. The reason that we're here talking about this today and how it applies to the Lyme community is, as they'll know, there's a massive crossover in symptoms. A lot of people have been diagnosed within the Lyme community, have been diagnosed with ME or chronic fatigue syndrome. So and another thing is that not every Lyme patient is necessarily uniform the same in the symptoms that they experience, although there is always a large crossover. So what sort of symptoms, Lyme symptoms, is the Perrin Technique beneficial for? Or how can it be applied to like the management?
So the Perrin Technique basically there's two parts of the Perrin Technique: the diagnosis and the treatment. The diagnostic signs are very real. And I've seen the questions, by the way. There's quite a few questions coming through.
We'll
get back to
we'll make sure we come to those at the end.
So the diagnostic is what I discovered in my research over 32 years ago. I started my research, but I discovered the physical signs of ME and fibromyalgia, and in those days, I was working with a wonderful Dr. Andy Wright, who's now no longer allowed to treat Lyme's because he was using tests that weren't used by the NHS. And unfortunately, he was suspended from working as a doctor. And I just want to pay his respects to him because he was such a good doctor. And we worked together for many years treating ME and Lyme's disease as well. And he sort of introduced me to Lyme's, and we noticed a lot of patients with Lyme's had exactly the same symptoms. And it was a form of ME. When it hits the brain, it becomes what we call neuropathiosis. And that neuropathiosis is exactly what's happening. The drainage goes the wrong way and into the brain. And it's due to years and years and years of problems affecting the sympathetic nervous system, from spinal problems. And we can see in all these patients, they've got spines that are not curved in the right way, and it affects the drainage in the spine, because it's not just the brain, it's the spinal cord that has these spaces. And it's not just the nose, it's through the eyes, the trigeminals in the cheeks, and the auditory pathways are all affected. And these drainage system, if it goes the wrong way because the sympathetic nerves are working wrongly, because of years of possible infections, years of stress, years of physical, emotional stress, years of immunological stress. They might be allergic to lots of things. And we're all suffering from terrible pollution in the world. And all that builds up to sympathetic nervous system, overloads and overloads and overloads. And then it causes certain signs. And the physical signs I have in my book and are there. One of the physical signs is the spine. There's problems in the spine where we can see, we can feel. We look at the lymphatics. And in my book, I have a picture as well, if I can find it. Yeah. This in my book, I have this picture of the varicose lymphatics, and you can actually, I don't know if you can see that. Can you see that?
Yeah, I can just about see that.
So you see that, and these are very unusual to see the little bobbly. This was in a patient where you could actually see it. We can feel these backflow of lymph causes like varicose veins, except it's hard to see because lymph is a colorless fluid. Blood, varicose lymph, you can see varicose veins, you can see because they've got blue. Lymph doesn't have any color in the, so therefore you don't see this bluish or purplish varicose vessel. You just see swelling, but it's very hard to usually see it. We usually just feel it underneath the surface, and all patients with ME and fibromyalgia have this varicose lymph. It can happen in other diseases as well, but we see it with Lyme's as well, and lots of other chronic illnesses. But then when I was examining the chest of the patients, male and female, all have this, then we found a tender point, and this has become known as Perrin's point. And this tender point is related to the sympathetic nerves and the lymphatics, and is a tender point in all patients. It's in my book. It doesn't matter. I mean, some people can't feel it themselves because it's not, you know, when you touch yourself, you're not as sensitive, but it's left. And it's sort of superior and just slightly higher than the left nipple is usually a tender spot in these patients. And this became known as Perrin's point. And then there was another tender point in the abdomen, which is famously solar plexus, also known as the celiac plexus. And if you've ever seen boxing matches, boxers can knock you out in your head, can also knock you out in your solar plexus. So that's the fourth sign. The fifth sign is much more osteopathic, and that's the cranial rhythm. The cranial rhythm in ME patients, in fibromyalgia patients, and in Lyme's is disturbed. So just to, I don't want to talk too much science because I want to, but just to explain.
I think there are some people that are really kind of rocking on the science. I saw someone was loving your explanation before,
okay.
but I know obviously we're getting quite a few questions as well. So I just want to make sure
we'll just go very quickly to the cranial rhythm side. And this is the diagnostics. The cranial rhythm is disturbed in all patients with ME, fibromyalgia, and Lyme's, and lots of other conditions as well. So all those five conditions, five signs have to be there for me to diagnose. And then you go through the history and symptoms to confirm everything. But so these diagnostic signs have been tested in a study we did in the British Medical Journal. It was published, BMJ Open. It's the reference is Hives et al. Lucy Hives was our research assistant, so it's Hives. But we set this research up within the NHS, and it was basically to look at these physical signs, and we showed an 86% of diagnostics just using the physical signs compared to 44% by an NHS consultant looking at ME patients. So it was really exciting news, and BMJ published. They found that only two signs were needed, but I use all five signs in the practice because we're looking at we're looking at other symptoms as well, and once you're much more experienced in using these signs as a diagnostic aid, it's very easy to feel what you're looking for with these patients. But the cranial rhythm was always a problem for a lot of doctors, not understanding what we do, and it's very simply explained. It's based on physics, and if you have a very big wave, like the heart rate, it's 50 to 100 beats a minute. That produces cerebrospinal fluid in the brain. Cerebrospinal fluid is produced by the blood. It goes round the brain, down the spine, and comes back and goes back into the blood, into the venous sinuses. So in the brain, the rhythm of the cerebrospinal fluid is 50 to 100 beats a minute. It's the heart rate. This is accepted medical neuroscience. Yeah. However, now we know there's some drainage through these spaces that drain into lymph, and the main duct of the lymph, the thoracic duct, has a very slow, shallow pump of around 4 beats a minute. When you have a very large wave coming together with a very small wave, physics dictates a third wave, and that's called the interference wave. That creates this third wave, and it's all throughout nature. You look at, go to a beach. Most of our visitors tonight have been to a beach and seen a big wave coming in and a small wave going out, and they clash together and produce a third wave. This is happening in the body. Cerebrospinal fluid is draining, as we now know, absolutely from the scans. It's drained. That's what that image was. Cerebrospinal fluid draining out of the brain into lymphatic channels, into the main lymph ducts, and that creates this interference wave from 50 to 100 beats a minute to 4 beats a minute. You create a third wave, and that third wave osteopaths call the cranial rhythmic impulse. Now, I hypothesized this in the paper in 2007 in the Journal of the American Osteopathic Association. It's only now in since 2017 this has been proven. So this is what we're actually doing. We're actually feeling this cranial rhythm is all disturbed because it's not draining out properly. It's the neurolymphatic drainage, also known as the lymphatic drainage. The Americans called it that because it was the lymphatic drainage from the glial cells of the brain. So it's known now by a large number of circles as the lymphatic system. But this neurolymphatic system is what I've been working on for the last 32 years. And this is why we're helping people, because the treatment is designed to stimulate the cranial rhythm, stimulate the lymph drainage down the head and neck, stimulate the drainage up the body and from the spine as well, creating a concertina effect in the drainage where the lymph drains into the blood. And the large molecules then drain into the blood and are dealt with by the liver, by your gut, by your waterworks, and it comes out sometimes through the skin. But that's what we do. We create this concertina effect, like a concertina instrument. And also that creates what's also known in physics as the siphon effect. And I always joke with some of my Liverpool patients, that's how you get your petrol. But I wouldn't. That's a Manchester
joke. If there's no Liverpudlians here taking
that's a Manchester joke, and if there's any Liverpudlians watching, I actually, this is going to be bad for the Manchester lot, but I used to follow Liverpool when I was a kid watching the football.
You might have redeemed yourself there then. So,
unless they're Everton fans. Anyway, but basically, if you ever had a fish tank and you want to get the gunge at the bottom, you suck up the gunge at the bottom of a fish tank, and then it goes out into the bucket after some of it going into your mouth, unfortunately. But that is what the siphon does. It creates this pressure change that continues draining, and that's what we do. We create this pressure change that eventually continues draining the toxins away, and eventually with ME, CFS, all the cytokines are going to come out. With the post-COVID, cytokines are coming out very quickly, very speedily when we get them early enough, and we change around the post-COVID, but long COVID patients very quickly with this. With Lyme disease, it's ingrained in the brain for many years sometimes, and that's where it's harder. So we need supplements and other things to do to help combat, and sometimes antibiotics long-term to combat the Borrelia that might be stuck in the brain. And the cytokines will drain out with the techniques, and eventually we get rid of all the inflammation in the brain, and the brain starts working again. And that's basically the Perrin technique in a nutshell.
So should we move on to some of these questions?
I think we should. I'm sorry, I've said much more than.
No need to apologise. No, that was really great. Really great explanation. Really useful. So we had one in the Q&A function that came through first, I think. So it said, "Hi, I've had ME for 27 years, and no, you're going to have to forgive my pronunciation because I'm not sure if it's going to be right. But Sherman's kyphosis." Yeah,
Sherman's. It's in my book. Sherman's is actually one of the things that actually is what we see again and again and again. There might be pictures that I've got in my slides I have, but we see the osteochondrosis or Sherman's in most of these patients, and that's where they have a curvature in the top of the spine, and they have a flattening in the middle part, and then have more curvature. And this problem, Sherman's, happens when you're developing during teenage years, and this is where most of the ME patients develop a problem in the spine. Some have injuries before, but if they're very active as a teenager, they'll develop Sherman's. And this is an osteochondrosis condition of the spine where the spine develops slightly wrongly, and this will affect the lymph drainage along the spinal canal, and lymph drainage down the spinal nerves. You've got these perivascular spaces, and they're going to be affected if the spine is dysfunctional. So we see usually a very flattened spine,
Right.
and that's one of the physical signs. And
Yeah.
it's Sherman's causes this problem, and we see it again and again and again.
Yeah, so this guy says he feels that he's in a subset of one because he can't find anyone else with these two conditions, and he has to.
Well, there's every patient virtually I've seen who's developed ME during teenage years has developed it because of Sherman's.
Right.
And so there's millions out there with it. Thousands.
Maybe he might benefit from.
Yeah.
Checking out the book or something, reading it.
Well, it mentions it mentions that if he looks at any of my lectures online, then it will show I talk about Sherman's even 20 years ago, 25 years ago.
So he's not alone. That's
not
that's
alone
one
at
thing
all.
to say
It's
for sure.
what we see. Yeah.
Okay, and I think the next question that came in was, do the nerve roots get inflamed in Lyme or during treatment, causing numbness, tingling, etc.? I don't know if that's...
Yes, well, the drainage, once the drainage doesn't work properly, there's a buildup of toxins, built up in inflammatory toxins around the nerve fibers and around the nerve endings in the spine, and that can cause irritation. But what's more important, it's the sympathetic nerves. When the sympathetic nerves are irritated from the lymphatics, when they fire off, they're very close to the surface in the skin next to sensory nerves. Deeper in the body, sympathetic nerves go alongside blood vessels, but next to the surface of the body, they go alongside somatic nerves, the nerves that control sensation and movement. And there's, among what's been proven now, where there's two parallel nerves next to each other, it causes there's a connection between the two nerves called epapses. Everybody's heard of synapses or synapses, where the nerves join each other, but these are epapses where the parallel nerves fire off to one another. And this happens with somatic nerves and sympathetic nerves. So if the sympathetic nerves are all irritated, then sensory nerves will be irritated, causing numbness, tingling. And again, it's all in my book, where I have a whole list of over 100 symptoms affecting people with ME, and numbness and tingling is explained in that. Exactly what now. Yeah.
Thank you. Next question. If you don't suffer fatigue, is that a sign that your lymph system is working okay? Or if fatigue isn't a big issue for you, but other symptoms like neurological and mast cell reactions, will Perrin Technique still help you? Right.
Well, fatigue can be done. It's one of the things that, the main symptom of ME, chronic fatigue syndrome, is post-exertion malaise. So the fatigue is this post-exertion malaise. So what do I mean by that? Do I mean physical fatigue? I've had some patients who are athletes, and they're still quite fit physically, but mentally, any mental fatigue, they get this brain fog, and that's mental fatigue. And sometimes that's the main area, but sometimes it's pain. And pain, if it's much more pain, it's these areas, going back to where I said, if you remember, I said when the drainage doesn't work, it goes into areas of the brain like the limbic, part of the limbic system, the thalamus and the basal ganglia. Basal ganglia contain GABA as a main neurotransmitter, and GABA, gamma-aminobutyric acid, is a pain suppressant. So when toxins hit that, when they go backwards instead of coming out, this vicious circle that ensues, that the toxins build up, and that causes sympathetic problems, which cause the lymph to pump more and more toxins back, and that's what leads to ME. And this toxic backflow hits this affecting the basal ganglia first, and therefore there's a lower level of active GABA, which means there's more pain. There's also the thalamus contains NMDA receptors, other receptors, which are very important receptors that stimulate another chemical in the brain called neuropeptide P. And neuropeptide P It's stimulated by the NMDA in the thalamus area, right next to the hypothalamus, and this stimulates pain. And when you have more toxic buildup there, it actually stimulates more pain. So there's two areas which are the central areas of pain that could cause major pain and not too much fatigue. And this, I believe, is what causes fibromyalgia, where it's much more pain than fatigue. And if you have no fatigue at all, you can do everything. And you have no mental fatigue, it's unlikely to be this problem. But there have been some strange cases over the years that I've seen people who don't get fatigue, but they've definitely got ME. But it's very unusual. It's not usually diagnosed if you don't have any fatigue, if it's mental or physical. But the toxic overload can affect different parts of the brain. And this is the thing, it usually affects these areas. It usually affects the areas that are concentration, but it can affect any area of the brain. And this is where other diseases are being recognized as a problem of the neurolymphatics. I've just read a paper that talks about but Alzheimer's, we know, is a definite problem. A lot of research is done on that. But I've just read a paper now where they're looking at Parkinson's as one of the major causes of Parkinson's, they reckon, is a problem in the drainage of the brain, the lymphatics. And there's probably so many other disorders in the brain affecting it. So this person could have some other problem, not ME or fibromyalgia, that's due to the lymphatic drainage of the brain, and the treatment should help. Yeah.
Okay, fab. Someone said here they're keen to know how a Lyme patient can help themselves through massage. Is that possible?
Yes, but if they do massage just willy-nilly without actually any training, it's best to get a practitioner who understands how to treat the body as well. If they do it just by themselves, they might help themselves. For ME, for instance, I had a patient who wrote a whole book about how they used the Perrin technique and a few other things and supplements, and they got themselves better. And they said they've actually written a whole book. I said, flattery is the imitation's the sincerest form of flattery, and I'm very happy they've placed my book into this in America. But at least they mentioned me. But
they get some credit, yeah.
Get it. But the thing is that there are people who can do self-massage, and but it's better to be guided with a practitioner on board as well, because it's so easy to overload and to take out too many toxins too quickly and make you much worse. There's usually a backlash to the treatment to begin with. As the toxins come out, it does what it says on the tin, as we say. It's important to get the toxins out, but it does affect the body as the brain drains off toxins. The brain doesn't have any pain receptors in, which is interesting. So when the toxins come out, they'll hit brain receptors in the head first, causing more headaches usually, and for other things. So it's best to have a professional there to guide you through it. Better out than in, but you need to have it right. And that was famously made a phrase made famous by Shrek. Very highbrow, this talk.
Yes, absolutely. Can't go wrong without a bit of Shrek.
It's actually Paul Cézanne that actually said it for those highbrow people. Paul Cézanne, the artist, said better paint out than in. So that's where it started from. Anyway.
Now, this kind of relates to, not that specific, not Shrek, but this kind of rate of conversation kind of relates to a few similar questions that I've seen in the chat about using Perrin treatment as Perrin technique as treatment. So I guess it's a two-level question. One is Perrin technique treatment alone enough to treat Lyme? Or is it more a management of symptoms? And then separately, two people have kind of asked, how long does a course of treatment take? How many sessions are you supposed to have with Lyme?
Well, how long's a piece of string? Lyme disease and ME and fibromyalgia can affect patients in different ways. There can be patients who are still active, doing things, but have got Lyme's, and or some who are completely bedridden in darkened rooms, who are unable to speak, unable to do anything, communicate with the outside world. And that's the difference. And that's usually, people like that should never exist. And patients are like, I'm so upset with it. I see when I get called out to these patients, because it's a build-up. They should have never gone to that level.
Gotten to that point.
If we get
that was one of the
patient.
questions I posed to you beforehand. Sorry, wasn't it, Ray? Because I can see the where you're going, and I want to make sure that we touch on this point because this lady sent in the question beforehand. But you're kind of speaking about people like her daughter who, you know, has severe ME and CFS, who's bedbound, has very little energy, is very extremely sensitive to touch. You know, so they wanted to know if there was anything gentle or light touch they could do.
Well, the crane, if they're very severe and they can't touch them, we first have to reduce the pain and sensitivity, and that's where analgesics and certain medicines that will help the brains cope with pain. Maybe something like, not saying this is, but I mean, presumably if she's very sensitive to touch, gabapentin and pregabalin and things like that have been tried, but you can't treat the patient if they can't touch. Cold on the spine, cool on the spine, warm on the muscles, if she's got severe fibromyalgia, usually works. So just a cool pack, not freezing, just a cool pack, just bearably cool. So if she can't cope with much, then it'll be a very, very cool, very mildly cool pack on the spine, and warm on the muscles usually help most of my fibromyalgia patients. And then if they need painkillers as well, there's lots of different natural painkillers out there, which I mentioned in my book, but also there's the pharma, and sometimes you need pharma to get to the next stage of treatment. But cranial techniques, very gentle cranial techniques and gentle articulatory movements without too much massage might be what she needs, but it has to be so gentle and little and often. So a practitioner who lives nearby could probably help, but it needs very regular, very small amounts of treatment. So
and just in general, in that, where we started answering that question about you know, what a typical appointment is, how many treatments you need, and could you use it as treatment alone?
Well, yeah,
I mean, I think your answer to how many you would need is individual to any particular situation. So there's no like one set treatment course.
Yeah, well, when my practitioners, the trained practitioners who I've seen, they'll be able to score the illness. So we have a score for ME out of 10. 10 out of 10 is perfectly healthy. Zero's dead. And I always joke with the patient, well, you're not zero. And see how they smile. And if they do laugh a bit when I say that, then I know that they're not suffering too much from depression. I mean, the name, I don't know what age the audience is, so excuse my lingo, but the name I use for ME is TPOS, and this can apply to Lyme's and fibromyalgia as well. TPOS. It stands for thoroughly pissed off syndrome, which is the best way of describing ME and fibromyalgia and Lyme's. And you know, the patient is so fed up and just so, they're going from pillar to post, and not many of the doctors they see understand what's going on, and they get worse and worse and worse as they try different things, as they try the graded exercise, the dreaded graded exercise programs that were famously put into place after the NICE guidelines came out, and then that's all changing now. But there's still a lot, you know, they're still talking about this with post-COVID, long COVID. They're saying, you know, get out and do more exercise, and I'm saying no. But you've got to rest. The cornerstones of anything with ME, as soon as you start feeling these symptoms, I use an analogy I call the jigsaw puzzle analogy. When you make a jigsaw puzzle, which I like doing occasionally, you start with the corners first, and the corners of the treatment, treatment on Lyme's, and treatment on ME, CFS, long COVID, fibromyalgia. It's got to start with rest. Relaxation is so important. So it's not just resting, you've got to relax with it. And then you've got to, if you can't relax, if you're still so stressed by everything or stressed by resting, then learn how to meditate, mindfulness and things like that. And then the last thing, which is the most important, is pacing. And I started the idea of pacing in 1989 when I first started treating patients with ME. I realized that they're being pushed, and they need to back off and reduce the strain on the sympathetic nervous system. So I have a rule, 50% rule, half of what you feel capable of doing. So patients with ME, fibromyalgia, Lyme's should only do half of what they feel capable of doing. This is the road to recovery. If you push yourself, you'll never recover. You just get worse and worse and worse. So you have to back off and pace. And then the corners have been put in, then you need the edge pieces. And the edge pieces is why I believe the Perrin technique. Looking at the mechanics, the biomechanics, looking at the structure, looking at the drainage of the brain and the spinal cord and the drainage of the central nervous system, and getting that working properly. Once you've got the center and the edges, then you go forward and start putting the sky and the sea in. And some patients are 50-piece jigsaws, some patients are less, and they're easy to do, and they follow everything the right way. And some patients are 1,000-piece jigsaws, where you've got lots of different disciplines that you need, maybe different supplements, different medicines, different talk therapies, whatever they need. And then one patient said she must be a baked beans of jigsaws. You know, they're so complex. But we have to find the answers, and everybody's different. Everybody's a different jigsaw. So, and that's where expertise comes in, and that's what I train my practitioners to start looking and dealing with this area. Yeah.
We've still got quite a few questions, Ray. Are you okay to?
Yeah, I'm fine. No problem. Yeah, no problem at all.
So this is a bit of a lengthy one, but I'll do my best to try and get through. So they said they began the Perrin Technique in 2017. Said she was your demo patient in Hamburg, apparently. She said she began to experience a positive sensation of thick glue oozing down the outside of the back of her neck. It was most pronounced at or after midnight or late afternoon. It helped relieve the pain and the encephalopathy, I hope I'm saying that right. I have chronic Lyme. Perrin Technique helped me greatly to detox and with the pain. Now, however, the feeling as if my body is full of thick, gloopy fluid trickling out of my brain is constant. Overnight in particular, the fluid collects and I have to do the massage on waking and also yoga to drain the fluid. It became more intense last year after taking disulfiram for a year, which was hard but helped me greatly. I also have a gene for cystic fibrosis, but not from both patients. Yet, could this be playing a role? Is this familiar to you? How long will it last? Can I do anything else? She's currently on the Boona herbal protocol.
Okay, right.
Bit of a meaty one there, I know.
Right, well, there's a meaty one, but I remember the Hamburg. There was a Hamburg patient that had other treatments as well. There was a osteopath that came in. I don't know if it was the same one, but so no, I've done a few work in Hamburg. Because Hamburg, there's the Osteopathic School of Deutschland, which I'm attached to. So I go give workshops there. So I don't know which one it was that she was at, but yeah, the thing is that the treatment is not I'm not the cure all. I'm not saying that. I'm not a magician. I have in my practice here a picture which I will show you. It's visual, and I have this in the back, and I say I don't do magic, but occasionally I do, and it's me at Harry Potter Studios, flying, but I'm not a magician, and I don't have all the answers for every patient because there's other conditions obviously going on with this patient. So the drainage is something that is important, but there might be other things producing toxins all the time that needs to be addressed. So if she has other neurological conditions, there are other conditions of the body, these need to be addressed possibly by another physician. And often I work together alongside other physicians, other doctors in getting the person better, because it's not just my treatment. I'm not the cure-all, and there's no cure-all for these conditions. So it's a part of the picture, a part of the jigsaw puzzle. I said with this patient, she's got obviously lots of sea and sky in the middle, and she's a large number jigsaw. So there are other conditions going on with her, obviously, and this needs to be addressed by a consultant in that field. So she should have further tests done, she have scans done and other tests done to find out exactly what's going on. But there's obviously something continuing irritating the brain, creating more and more toxins all the time. So we have to find out what that is, and that's where a good physician comes in.
Okay. Thank you, Ray. Next question, is Eagle syndrome seen in these issues? I think they mean, he said that he does say in brackets, although this may not be relevant to the doctor, but does he encounter or know of it or the issues it causes, as lymph and swelling issues in neck and throat can be long-standing symptoms in Lyme?
Eagle syndrome.
Yeah.
That's an interesting one.
I mean, he does kind of say if it isn't something you're
no,
I think he's just asking on the off chance it's something you've heard about.
Well, it's a disease of the it's a part of the pharynx in the face. It's recurrent pain, and because
Not
it's
something
after trauma or tonsillectomy. It's interesting because the tonsils are part of your lymphatic system, and it's symptoms include dull and persistent throat pain that may radiate into the ear and worsen out an edge. Who knows? This could be a really good one. I've not addressed patients with Eagle syndrome, but there's a good chance it could be. That could be a link. It'll be interesting to see if anybody's done research of Eagle syndrome and neurolymphatic drainage. But one thing we do know is the lymphatics, the tonsils are part of the lymphatic system. If you cut through the lymphatic system and remove part of it, you're going to affect the lymphatic drainage in this area. And it also affects the neurolymphatic drainage, and it could cause a lot of these symptoms. So maybe Eagle syndrome is
maybe there is something in there.
I know one thing for sure, and this is going to upset a lot of women who may want to have a breast enhancement surgery. But anybody who does should think really about against it, because when they do breast if they're doing implants, they get a medical spatula, and they cut, I'm sorry, it'd be gruesome, but they cut beneath the breast and they actually rummage through the lymphatic vessels. So they're actually damaging so much of the lymphatic vessels of the breast tissue when they're actually cutting through here. And I've seen the surgery myself, and I've seen what goes on, and I just think, oh my gosh. And then they put the implants in, and then years later, these people who have had implants start getting fatigue syndromes, get ME, and it's classic. You see this again and again and again, and it's not the implants. The implants, unless they had the poisonous implant that happened in France a few years ago. But the standard implants, the silicone and saline. Silicone could be toxic. Saline generally not, although I have got silicone implants. Silicone part of the saline usually, but even if they're not, it's not that's a problem, it's the surgery. And so that likewise, if you have a problem in have surgery in other parts of your lymphatics, it could lead to problems later on in life.
Fab. All right, next one. Vicky, lovely Vicky, says, this is a fascinating talk. Thank you very much. And thank you to Ray. He's the fascinating one. Said, I was diagnosed with chronic Lyme last year, having been housebound for 5 years. I've heard mixed feedback on when you should start Perrin Technique. Some say early on in treatment, but others say it's best when you're a bit stronger to deal with the release of toxins. What is your view, please, Ray?
Well, as I said, it's very, very much patient related. You've got to be sure not to overload the patient, so we don't just gung-ho go into it. And that's why going to see somebody who's trained in the field, who's by myself, who's licensed. I'm starting this year to start training trainers, because I'm not getting any younger. I'm not going to be here forever. I've not worked out how to stay immortal. Although I have got a lanyard with from Manchester University, because it's an honorary position, so I don't get paid. So it's a lanyard that says I'm in Manchester University to the year 4,100 and something. So I've got a few thousand years to go. But when I eventually do leave this world, I want other practitioners to be teaching my techniques. But if you go to a trained practitioner who knows what they're doing, or even somebody who doesn't, who's a good clinician who can take my book and use it, I'd say, you've got to be every patient is different, and you've got to be treat every patient softly. We go very gently into it at the beginning. And if you're taking a patient who's had it for years, or then there's usually going to be more and more complications. The quicker you get there, the better, really. And if you can, I'm the only one in the world that says you can prevent these problems, because the neurolymphatics, the signs are there usually in the very early stages, and sometimes in families. There's a question here: could this explain links with genetic predisposition and family history? Sent by Katie. And that, yes, it can. Yes, and we do, and we see it in 15% of all patients with ME is familial, and I see mothers and
15,
daughters,
15, or
15%. It's been a study done by Jesus Castro from Barcelona. Professor in Barcelona has done a lot of research into ME. He produced a paper showing 15% of ME patients that he was seeing in the study were familial. And because we look like our parents often, because our facial genetics are very similar, and likewise the cranial genetics could be very similar. So if you've got a problem in the cribriform plate, the main drainage of the brain in this area, that could be genetic. And the spine, a lot of people have spinal problems. Osteopaths, we can see, I can tell you your father's son or your mother's daughter because of the spine. And so spinal mechanics can be hereditary as well. So the genetic predisposition is there from the biomechanics, as well as other conditions affecting the body. So we see a lot of familial links with this. So that's what explains, and the genetic predisposition for it. I don't know why I got into that.
No, it was well, that was the separate question, but it was about the person who was asking if there was a particular time, should you wait a certain
so therefore we can actually get to the patient before they even start. So I see patients who have children who haven't got the symptoms, but they've got some of the signs. And unfortunately, I can never prove that my treatment prevents ME, but when we've treated these people, the signs usually disappear because we catch them early enough and they're younger, and we stop them getting ill. The trouble is, critics could say they'll never get ill in the first place, and that's the problem with preventative medicine.
Yeah.
But
And you're talking about, seeing a practitioner. One of the questions here was how do people find a qualified Perrin practitioner? Can you?
Yeah, well, there's a Perrin link. I don't want to be too much in advertising the Perrin Technique because it's not what it's about. But the Perrin Technique website has a map with the local practitioners. Unfortunately, worldwide, there's not as many as we want. I have trained practitioners, but a lot of them don't want to sort of sign up, and they just want to do their own thing. They learn the knowledge. So there's people out there that have been on my training courses and know the knowledge, but they don't actually, they're not
register themselves.
But because a license means that I'm doing continuing professional development with them. They come on workshops, they come on conferences, and I'm liaising with them, and they're much more I would say qualified to deal with this. But there's lots of practitioners out there who could take the new book and take it all in and hopefully help the patient. So if they haven't got any local practitioners on the website, then they can find an osteopath or a chiropractor or physio who's trained in cranial techniques. That's so important. They need to know cranial, because cranial is part of the Perrin technique. And they will, so if they look on the website, they haven't got anybody nearby, then just go to the nearest osteopath, physio, chiropractor who's trained in cranial and ask them if they're willing to take it on. And if they are, then they can always ask them to come on a training course with me later on when I'm in their neck of the woods. We are starting to run training courses. With COVID, it's been difficult, but I'm starting my first one in London in June, end of June, and going back to Europe next year. So I'll be going to Hamburg later on, later on this year. We've been delaying it for a long time because I'm attached to the European colleges, but I can't train up these practitioners to do the undergraduate osteopaths to do the techniques because it's hands-on and they need to be there.
We still got a few more questions. Are you okay to?
I'm okay. I'm okay.
Sure?
Yeah, absolutely.
Do say if you need to,
Yeah,
your wife's waiting for you at home with your dinner, but we'll try and get through a couple more.
She's always waiting for me.
Oh, bless her. Someone else, would this be relevant to chronic symptoms like vestibular disorders, including dizziness and disequilibrium? Oh,
yeah, well, dizziness.
You guys are really testing me today.
Yeah, right, well, dizziness. Yeah, the dizziness, and one of the triggers for a lot of times the vestibulitis, which is an infection in the middle ear. This is one of the common trigger for ME. The people who had treatment for vestibulitis, and then eventually they're dizzy. Vertigo is very common, and it's because one of the main drainage points of the brain is the olfactory, not just the olfactory pathway, but the auditory pathway through the vestibular cochlear nerve, the auditory nerve, and this nerve is a cranial nerve that has cerebrospinal fluid down the blood flow next to the nerves, this perivascular space. And again, if this is building up in there, it can cause problems in hearing. A lot of times patients with ME, fibromyalgia, and even Lyme's get hypersensitive hearing. They get hyperacusis, and sometimes they get dizziness, and that's one of the main reasons. But there's also blood flow in the brain affected because of sympathetic control, and that can cause dizziness as well. So there's two causes.
Oh. How about chronic sleeplessness? Someone's asking about that. I think they're saying it's due to long.
Yeah, right. So one of my theories of the whole of ME was that the hypothalamus, and I have in the first picture in my book, and if I can find it, it's the first picture in my old. Yeah, it's still the first picture in my new book. It's this one here, figure 1. Okay, now in there we have an organ. I can't show you; it's a bit too small for showing. But there's the hypothalamus, which is connected to. If I was right about the sympathetics, which we've now shown, there's lots of research showing I am, then the sympathetics in the brain is stimulated by there's a chemical in the brain and the rest of the body called noradrenaline. It's like adrenaline, and it's produced in the brain in the locus coeruleus. It's also produced in the adrenal glands as well. And this, in America, they call this norepinephrine. So it's got two names. And this is produced by the locus coeruleus in the brainstem. So I said in my original hypothesis in 2005 and in my thesis and my first book, I said, if I'm right about the sympathetic nerves being wrongly affected, being disturbed, there's going to be an effect on the locus coeruleus. And the hypothalamus locus coeruleus axis is going to be found to be a major problem in the drainage of the brain. And the studies done by Jeff Iliff in 2012 that showed the first signs of drainage of the brain in mice. They saw the visual that this drainage did occur in the spaces, but it was in mice. They looked at these mice and they watched what happened to these mice when they were asleep. And they also put some of the mice to sleep. And when they went into deep sleep, delta wave sleep, the hypothalamus locus coeruleus axis switched off. And that was proof that this axis in the brain was a major part of this whole problem. Because when it switched off, they saw the drainage occurring. So it's during delta wave sleep that this lymphatic system, this neurolymphatic system, was shown to occur. And it was only when the hypothalamus locus coeruleus axis switches off, which is why ME patients don't have, well, Stanford University found that delta wave doesn't happen much in ME patients during nighttime. So at nighttime, this doesn't switch off. The hypothalamus locus coeruleus doesn't switch off. It stays wired and fired. So patients find it very difficult to sleep, difficult to get to sleep, and difficult to stay asleep because they're not having this, they're having alpha wave, and they wake up the next morning feeling unrefreshed because the delta wave hasn't happened during night. Stanford discovered that delta wave happens during the day with ME patients.
Right.
And this is then for the drainage that occurs during the day, making them feel sick, making them feel tired because it's deltoid, and making them feel awful because all the toxins are coming out during the day.
Right.
And then
So
at
some of the
night time,
functions that should happen at night,
it's happening during the day. But this has been now proven by Stanford's work. And then what we need to do is we need to redress the balance. We need to get the delta wave at night time, and we need to stimulate this drainage at night time. And that's what we do with the work I do. Is we give the self-massage to do. When they do the self-massage, we tell them always do it at night time before you go to sleep. And that should help the drainage at night time. And then you wake up next morning, hopefully feeling more refreshed.
That's so interesting. Well, I guess we should probably finish on the couple of questions that we've had about your book, because that's what kind of started off our conversation, you and I. And I'm sure I'm really sorry. I know there are some more questions, but I'm well aware that we're already 25 minutes over, and Dr. Perrin does have a family to go home to. So I
just seen one comment. Sorry.
Yeah, no, please do.
I just saw someone comment saying, I trained my partner to do it. I don't know who. It's from Leonie Green. Yeah. I trained my partner to do it during lockdown using the book. First sessions felt lovely at the time, but a few hours later, like being hit by a bus. Took 4 or 5 sessions to get manageable. Yeah, well, I said that if you do it yourself, you have this problem that it can get worse before it gets better. We know this. And but eventually, once you've drained off the toxins, you will start feeling better. But be careful about doing it yourself, because we have techniques of cranial. We're going to be doing research. I must mention this. We're doing long COVID research at the NHS. We're giving self-management to see if patients who have been diagnosed as COVID respond better when they do the self-management. So there is it's going to be interesting to see if it works without any practitioner involved, because NHS can't afford, obviously, to pay for them. So we're going to give these long COVID patients in Manchester the chance of doing the self-massage. We've got videos and doing cranial techniques where putting a book behind their head in a certain position. If it's comfortable and they're happy in the right position, it can actually help the cranial. So we're going to do self-management, and this is going to see if they respond better and get better from the long COVID quicker than the patients without this self-management. Very interesting project, starting very soon, and I'm working together with Salford Royal Hospital, which is an NHS trust hospital, and a whole team there. So I'm very privileged to work with them, and so hopefully we can get this through the whole, if it's successful, through the whole country and maybe throughout the whole world. That self-management can help, but we're a long way from that stage yet.
Yeah.
But if you want to do it yourself, you can, but there's a risk. It can make things much worse. And if you think that you're getting worse and worse and worse and you're not improving, I would say stop and try and get to see a practitioner. But it's much safer to see it somebody and not try it yourself, because it can be dangerous.
And so where can people pick up your book? Because I saw someone mention that they'd seen the 2007 edition as well, and they wondered if there was a new one.
Well, you can get my book from the best way. All the book suppliers have the new Perrin second edition.
I think someone said they couldn't find it on Amazon.
This is the first edition. The Perrin Technique second edition is on Amazon.
It is on Amazon.
Definitely on Amazon. It's on all the bookshops, Waterstones, all the big bookshops, all the book supplies will have the new book, the second edition. They also have a Kindle version. There's a Kindle version. We're working on an audio version because a lot of patients can't. Now, this is the old book. It's much smaller. It was only, and it's much easier to get through than the big book. The big book is more reference text. In fact, we have the back of the book. Dr. Adrian Hild, consultant physician at Salford Royal, said for anyone who's involved in the diagnosis and management of ME/CFS, this is an essential read and a seminal reference text. So it's more reference than, but a lot of patients have been reading it.
There's lots of case studies in there as well, there aren't there?
Yeah, and it's case studies from each chapter has patients.
And it has a special chapter on Lyme as well, doesn't it? And
there's some sections on Lyme. There's a few paragraphs on Lyme, and then we talk about Lyme quite a bit. But there's not a separate chapter, but there's a section on it.
Right.
But the thing is that the book is available, I said, on Kindle as well. It's definitely available at Amazon. There's, if you can't get it from anywhere, if you get in touch with my practice in Manchester, we can send it to you, depending on where it is.
I think they found it now. Whoever couldn't find it on Amazon before has found it. So
okay, so hopefully you'll find it useful. We are working, and we're finished. We're just working on the editing side of things. A patient handbook, which is to go with this book. And there's going to be a smaller book which just has the things that are essential for patients, to the treatment and the diagnosis, that they can understand without going through the whole of the book. And that's going to come out probably in early autumn. So that's going to be a much smaller book, and it's for patients that can't read a lot, and most of them can't. The first chapter says it all, really, and that's in the new handbook. And it's also cheaper, so it helps save money for the patients who, I know obviously most of them aren't working and can't afford. So that new handbook will be coming out hopefully very soon, in early September, I think it's due to come out.
Okay, fab. So people can keep an eye out. And we're having a few comments there on the chat function. You can probably see, Ray, just people saying thank you very much, and how what you're saying makes sense. So
yeah, well, that's when people know more about it and they read more, they say, God, that makes so much sense. And science is nothing but organized common sense. Thomas Huxley said that, not me. So hopefully you've enjoyed the talk, and good luck to all you who are watching who want to try and help yourself. But the earlier you get these conditions sorted, the better. And I said prevention, if you're in the family, if you have some people with minor symptoms, then get them to be checked out. And if they have the physical signs, get them some treatment. So anyway, thank you very much, Rosie.
Yeah, no, thank you so much for your time.
My pleasure.
And thank you everybody for coming. I hope you've enjoyed the talk. Everyone's chatting on there and saying so. We do these events for free with absolutely no obligation of support. But if you have enjoyed it today and you'd like to make a small donation to say thank you, or just support a charity that's looking to fund research into Lyme, I've put the donation link in the chat. We'd be very, very grateful, but please, only do so if you feel moved to and are able. But just a massive thank you, Ray, for your time tonight and for extending it, way over time. Clearly everyone.
If anybody wants to know, what this badge is, it's the DOV Gold Award that I was given by the Duke of Edinburgh himself in Buckingham Palace in 1978 when I was 18 years old. And so I thought it's apt to wear it for this occasion.
A little mark of respect. You've done well to not lose that since 1978. Well, I know,
and I don't dye my hair either. So it's a freak. I'm a freak of nature. This is it. Yeah. So maybe I'll make it to the year 4000.
Maybe you will. But yeah, thanks again so much for coming. We'll let you go home after your
and good luck with all your work and the Caldwell work that he does. So
thank you. And just as a reminder to everyone, this session's being recorded, so if you missed any of it or you want to rewatch it, we'll be sending out an email tomorrow with the hopefully tomorrow afternoon with the recording. But yes, take care, Ray, and everybody, take care of yourselves, and hopefully catch you again soon.
Okay. Bye-bye.
Good evening, everyone. Bye-bye.